Good afternoon, everyone. If you don't mind, if we can make it a little bit more interactive, is that okay? So probably moving forward, we have to have more interaction because I really want to understand from you guys if you get the point or not. So uh, if you don't have to have a tie. Uh, anyway, so some questions about WPW, it's kind of, I'm going to mention a few things and probably at some point we'll talk about supraventricular tachycardias. But when it comes to WPW, you have two ways of having fast heart rate related to WPW. When you have accessory pathway, you either going to have, kind of wide complex tachycardia, or you may have narrow complex tachycardia. Uh, the issue with WPW, when you have accessory pathway, there's always certain contraindications, which are the beta blockers, calcium channel blockers, or digoxin or adenosine to be given to these patients when they have tachycardia related to WPW. Treatment of choice for WPW is ablation. However, when you have tachycardia related to accessory pathway, in the hospital, what you can give usually prokinamide IV. As far as EKG pattern with WPW, if you see short PR interval and wide QRS, so short PR interval, not enough, you have to have wide QRS with it to identify the WPW pattern, and the WPW syndrome that was described by Wolf Parkinson White. You have to have WPW pattern and the tachycardia or history of SPT. So not every short PR interval is WPW, and short PR interval with wide QRS is WPW pattern, and not every WPW pattern is going to be associated with SVT. And the treatment for that down the road is ablation. But be careful and be aware if you see patient with WPW, you have to be very careful about beta blockers, calcium channel blockers like the cardizem or diltiazem and verapamil, and you have to be careful in digoxin and adenosine in the ER. Do you have, guys, any question about WPW? It's really very complex. Probably at some point we have to mention something about supraventricular tachycardia and arrhythmia management and the way you handle that acutely and clinic facility as well as the hospital.
I have one question.
Go ahead.
I had a patient in a nursing home who had an ablation.
Yes.
Can we still use those medications?
Absolutely, yes. So it's the reason we don't use these medications, because if you go into atrial fibrillation in the accessory pathway, if you have accessory pathway and you're in atrial fibrillation, we give this medication. The medication is going to slow conduction via the AV node and hasten the conduction via the accessory pathway. So you're going to have open connection and line between the atrial fibrillation atria and the ventricles, and the patient is going to go into ventricular fibrillation, because as you know, the AV node works as a shield, as a filter. And when you block this filter by digoxin, adenosine, calcium channel blockers, and beta blockers, you're going to go into VF. And that's a no. That's the easiest lawsuit you can have it. But however, if you ablate the accessory pathway, you don't see it on EKG. In that case, you can actually do these medications. Is that clear, guys? All right. So the other questions. Yes. You have questions?
Yeah.
Okay. All right. So valvular heart diseases. So now I'm going to have actually, we have to finish by 4:30. So we can talk a little bit about valvular diseases. Let's talk about aortic stenosis. You have 3 degrees of aortic valve stenosis. You have the mild aortic valve stenosis, which is area less than 2 and more than 1.5 centimeters squared. You have the moderate aortic valve stenosis area between 1 to 1.5 centimeters square, and you have severe aortic valve stenosis with area less than 1 centimeter, equal or less than 1 centimeter square. Uh, the pathology of aortic valve stenosis is degenerative disease, senile aortic valve stenosis, you have the same pathology that, atherosclerosis and calcification. Uh, and uh, and the bicuspid aortic valve, if you have a little bit younger patients, you have a unicuspid aortic valve. I have one patient with unicuspid aortic valve. Prevalence is extremely like 1 per 1,000 of aortic valve stenosis. So it's very unlikely to have it, but usually they get the aortic valve stenosis in their 20s and 30s. Uh, the treatment of aortic valve stenosis is surgical intervention, obviously. You really don't do anything if the aortic valve area more than 1 centimeter square, or if your gradient less than 40 millimeters of mercury, the mean gradient. So the mean gradient less than 40 millimeters of mercury, if you have the velocity across the aortic valve less than 4 meter per second, you don't do anything. You just monitor your patients. Usually we do echocardiogram once every year for these patients. And if you feel that your patient is going into mean gradient of 36, 37, and the aortic valve area close to 1.1, 1.2, doing echocardiogram every 6 months, that's reasonable. The obviously treatment for aortic valve stenosis is replacement of the valve. Either you can do TAVR if the age above 70, or you can do SAVR, surgical aortic valve replacement, if the age less than 70. Let's say if your patient is with severe COPD and age is 60 plus, diabetes, multiple other issues, then aortic valve replacement via TAVR is a reasonable option. As we speak right now, there's really no medical management for aortic valve stenosis, nor you can adjust the natural history of the disease by any kind of intervention short of replacing the valve when it's severe. Probably whoever works with me in the clinic, they hear about, you have to be very, very careful with these kind of patients about preload and afterload. These patients, they tend to have a preload and afterload dependency. In other words, you cannot make them too hypovolemic because that will decrease the coronary artery perfusion. And because of the ventricle squeezing against a blocked valve, so the wall stress is very high, and that will affect the perfusion via the coronary arteries, and the perfusion, the coronary arteries is dependent upon the blood pressure, hence the afterload. So the afterload is the blood pressure in the aorta, and if you decrease your blood pressure too much, perfusion through the coronary artery is going to decrease, and your patient is going to have angina. And sometimes actually the angina is going to be bad enough that that your patient may go into VF arrest. So be very careful. I wouldn't try to make a blood pressure 100 or 110, and I would not try to make them extremely dry. So be careful about these kind of aortic valve stenosis patients, especially if you have somebody at the facility where the surgical or TAVR intervention may be too risky for these patients. Do you guys have questions about aortic valve stenosis? If anything we did not mention? Okay, so the aortic valve regurgitation, when you have regurgitation across the valve, mechanism is the same as aortic valve stenosis, senile valve disease, and bicuspid aortic valve, and in some cases endocarditis. Aortic valve regurgitation, you don't really do any intervention unless you have severe aortic valve regurgitation and end diastolic dimension above 5 centimeters, so dilation of the left ventricle. In general, the heart can handle leaky valves much easier than handling valve stenosis. So we can we can wait a little bit longer in aortic valve regurgitation and mitral valve regurgitation compared to mitral valve stenosis or aortic valve stenosis. And there's really not much you can do unless you have a severe aortic valve regurgitation acutely. In that case, you have to keep the heart rate a little bit faster, 100 to 110. The reason for that is the regurgitant volume is dependent upon your diastole. So if you shorten diastole, the amount of regurgitation is going to be less. Usually, this kind of treatment is acute treatment while you're waiting for surgical intervention. In the case of severe acute aortic valve regurgitation, probably you're not going to worry about that. But in general, if you have patient with severe aortic valve regurgitation, EF is getting depressed, dilated ventricle, in that case, surgical intervention is needed. However, if your patient has left ventricular ejection fraction of 60%, severe aortic valve stenosis, and asymptomatic, you can wait. Okay. Any questions about that? Mitral valve stenosis, when you have area of the mitral valve less than 1.5 centimeter square, in general, the mitral valve stenosis or gradient across the mitral valve more than 10 millimeters of mercury, the mean gradient. Aortic valve stenosis mainly because of calcifications and degeneration of the valve that could be related to rheumatic heart disease or could be related to functional mitral valve stenosis in the setting of severe calcification related to end-stage kidney disease. And the treatment for aortic valve stenosis usually is surgical replacement of the valve.
Are you, sorry, you're on mitral valve stenosis or aortic?
We're on mitral now.
Okay.
We're trying to rush through, guys. You gotta stop me and let me ask questions. So it's a lot of information. So you really need to ask questions for us to move, or we can stop here if you want. So we're on mitral valve stenosis. We already talked about aortic valve regurgitation.
Yeah, that's what I thought. Okay.
All right. So be more engaged, guys, please. Just ask questions. It's a lot of heavy stuff. Anyway, so the mitral valve regurgitation, if you're mitral valve stenosis, it's replacement of the valve. There's balloon angio or valvuloplasty that can be done, but usually it's associated with a lot of issues, and you should not have much calcifications to be successful. But usually the treatment of choice for mitral valve stenosis is surgical intervention. And usually these kind of patients, they are very symptomatic, especially with minimal exertion, and have atrial fibrillation in the setting of mitral valve stenosis. The reason is, if you have mitral valve stenosis, the left atrium is going to be huge because it has to squeeze against blocked valve, and that can have higher association with atrial fibrillation. So if you have AFib in the setting of mitral valve stenosis, that's really bad, and your patient is going to be extremely symptomatic. You have questions, guys? So I would recommend for you to go back to this lecture and read more about this lecture. Grady, what is the cutoff for aortic valve stenosis surgical intervention? Do you remember the numbers? Give me one number. Mean gradient, aortic valve area, or velocity.
Grady, you there?
Hey, hang on one second. Hey, I'm on with Tech from Encompass. We're having computer issues. I've got you playing in the background. I'm sorry.
That's fine. No worries. All right, guys, go back to this lecture, please. It's heavy stuff. If you want to really learn about the valvular heart disease, you need to know numbers. It's heavy stuff.
It was less than 1 centimeter squared.
Exactly right. Exactly right. So probably repeat lectures like that multiple times, and until you get to capture much information and capture these numbers. Remember that when you deal with patients, especially at the facilities and they are elderly, you have to take the age consideration, functional capacity of the patient, mental status, and so forth before you expose your patient to any kind of major intervention. Certainly, if patient is able to function well, and they have any of these kind of illnesses,
I have a question.
may be needed. Go ahead, please.
So on like aortic valve stenosis, it's preload, afterload dependent. So if I
Right.
have one of those patients and they're trying to be syncopal, like is midodrine harming them because
No.
it's going to make it work harder, or is that the right
No.
direction?
No. But when they reach the syncope, then the valve has to be replaced. There's
Okay.
triad or Braunwald's triad. Braunwald's is a cardiologist from Harvard, Brigham and Women's Hospital. He's almost 88 years old right now. He had tried if you have angina, if you have dystonia exertion, and if you have syncope, the valve has to be replaced. And if we are reaching that stage, then the valve has to be replaced. But absolutely, you're right. You raise the blood pressure, so perfusion to the coronary arteries will increase. And can I agree with that?
Okay, thank you.
Okay, guys. Any other questions? So we still have mitral valve regurgitation and tricuspid regurgitation. Next time we'll remind me, Nick. We'll talk about valves again, and please pay attention to this kind of stuff, because if it gets stuck with you, you're good. You know, cardiology is not very difficult. It's CAD disease, some electrical issues, some congestive heart failure business, and valvular heart disease, and that's cardiology. Anyway, good to talk to you guys.